Welcome to ATCM, the emergency medicine channel.
Yes.
66-year-old female, non-case of rheumatoid arthritis, hypertension, came to ER with complaints of breathing difficulty into 2 days. Initial 10-second assessment, airway patent, no pooling of secretion, gargling stridor, able to complete full sentence. Breathing, saturation of 99% in room air, respiratory rate of 24 per minute. On auscultation, there is reduced air entry on the right side. Decreased chest movements on the right side is also same. Then circulation, BP of 160/90, heart rate of 98 pulse per minute, and all peripheral pulse is palpable. Since disability 150, GRBS of 150 and temperature is normal, GCS of 15/15. So initial assessment, 66-year-old female, non-case of rheumatoid arthritis, hypertension, came to ER with complaints of breathing difficulty in 2 days, which was gradually progressing, associated with pain in the right chest wall, which increased on inspiration and cough with mucoid expectoration. No history of fever, central chest pain, palpitation, orthopnea, PND, no known drug allergies. Adjoint to primary survey, we did an ECG which shows sinus tachycardia and ABG showing a mild hypoxemia, that is pH is 7.36 and a PO2 72.6. CBC CRP showing a total counts of 7.2, HP of 12.9, platelet 204 and a CRP of 24.2. On examination, patient was conscious oriented, no pallor, icterus, clubbing, cyanosis, lymphedema. Respiratory system, we notice right decreased chest movements was there, and trachea is mildly deviated to left side. On palpation, we found the trachea is deviated to left and decreased air entry on the right hemithorax. On percussion, there is a hyperresonant knot on the right side. Since the other parameters are normal, like BP and heart rate is normal, we are taking it as a suspected case of stable right pneumothorax.
How do you diagnose pneumothorax clinically?
Is hyperresonant knots are there, decreased air entry.
How do you know that it is right resonant knot? One side it can be reduced, no?
Then
you are comparing right side to left side. Left side can be even reduced.
Also, patient given a history of recurrent pneumothorax.
Recurrent pneumothorax, reduced breath sounds, hyperresonant percussion note, then
trachea to
opposite side. Okay. All contribute to your diagnosis.
We did a point of care ultrasound on the left side. On the right side, there is decreased lung sliding is there compared to the left side, and barcode sign was also positive in right side. Then we ordered an X-ray showing right-sided pneumothorax. Since this pneumothorax, the apex to chest wall length was only 1.8 centimeter, but patient having recurrent pneumothorax, we did an ICD was inserted in the 5th intercostal space anterior to the mid-axillary line, and which was also kept under.
When did you try a needle decompression?
Needle decompression in most probably in a tension pneumothorax we have to.
What is tension pneumothorax?
Tension pneumothorax is spontaneous, sudden onset. Patient presented with sudden onset breathlessness. The air keep on leaking into the pleural cavity, causing hypotension and tachycardia. Like hemodynamic instability will be there.
Hypotension.
Hypotension, tachycardia.
What is Beck's triad?
Beck's triad is
described.
Beck's triad, cardiac tamponade.
What are the triads?
Muffled heart sounds. Then heart rate.
Bradycardia. Hypotension,
bradycardia,
and muffled heart sounds. So same triad can be there even in the tension pneumothorax if muffled heart sounds are heard only in the left-sided pneumothorax. But the same type of findings are there. So Beck's triad is sometimes used for this also. Okay. So this patient is not having hemodynamic instability, so it was not done.
Not done.
Where will you do needle decompression?
If the axis apex to chest wall length is between 1 to 2 centimeter, we can try needle decompression.
Where? Which position?
Second intercostal space or fifth intercostal space.
Which is current guideline? ATLS.
Fourth, like fifth intercostal space in mid axillary line.
Previously it was second
second
space for last guideline, but almost same. But it was that guideline. According to guideline, it is changed. That your point of decompression is changed now. Okay.
Then we moved to an imaging was done, HRCT done, which showing multiple cavitatory necrotic pulmonary nodules, including bilateral lung parenchyma with right-sided pleurothorax, pneumothorax. Features of bronchopulmonary fistula is also seen in the right side in HRCT.
What is bronchopulmonary fistula?
When there is a connection between bronchus and pleural cavity.
Okay.
So air get leaked into the pleural cavity, which has to be surgically corrected to prevent further pneumothorax. So we involve respiratory medicine as well as CBTS department for further management. ICD and further pneumothorax management was done by respiratory medicine, and definitive management of correction of bronchopulmonary fistula.
How do you know that ICD tube is working?
The air column, ICD tube is inserted into a water seal. The movement of air column in a water seal, we can say that.
Can you make out bronchopleural fistula here?
Using ICD, they won't be stopping. Like usually after decompression, if there is no continuous movement,
continuous bubbles will come. Okay, if it is a pneumothorax, just pneumothorax, the bubbles will stop, but you can see the column moving. But if it is a fistula, you will get continuous bubbles coming out. Okay, that's how in ICU we will make out. Then there are methods to find out, pulmonologists will find out. But for an emergency physician, you have to see this. One is column, or ICD column movement is one thing. If the tube is blocked, that column movement will not be there. If there is a fistula, you continuously get the bubbles.
Then, so in pneumothorax, basically, clinical features of pneumothorax. This is a case of secondary pneumothorax. We come because of bronchopulmonary fistula, pneumothorax occur. So the cause
minimal pneumothorax. Will you give oxygen?
Yes, sir. Oxygen we will administer for. First thing is there will be hypoxemia in pneumothorax patient, and also oxygen can help in reabsorption of air.
Okay.
So we will give oxygen, and observation we will do. Like if it is a primary first time pneumothorax, we will give oxygen, supportive therapies and observe the patient for 6 hours and discharge the patient.
Is it male or female, this patient?
This is a female patient, sir. Discharge the patient after resolution. I ask them to come to OPD basis in a respiratory medicine department. But if a hemodynamic compromise is there, we will admit the patient and observe for further evaluation.
What is catamenial pneumothorax? Is it? That's why I asked male or female. Here there is another problem. There are a lot of necrotizing nodes that might have produced causing this one. Catamenial pneumothorax, no. So during menstrual period, patient can develop bleed or pneumothorax inside the lungs. That is because of the cells are replaced in the lung as your shedding of cells there. Okay, so that is a rare phenomenon, but we have seen cases like that. Patient will come with pneumothorax during the menstrual cycles. Okay. So what is the reason for this pneumothorax?
For this patient, bronchopulmonary fistula.
No, what is the reason for that? Necrotizing nodes you are told. Is that
rheumatic
tuberculosis or rheumatoid arthritis?
rheumatoid arthritis can cause
Okay.
necrotizing in
Okay.
the lung, which can lead to fistula formation.
Okay.
It's pneumothorax.
What treatment she is taking for rheumatoid arthritis?
She was on MMF
Mycophenolate mofetil.
and
Any infection can produce pneumothorax like this in a patient who is chronically having immunosuppressive therapy.
HIV infection can cause.
HIV infection as such will not produce.
Like
What is
super
organic?
pseudocystic, pneumocystic.
Pneumocystis jirovecii pneumonia. That is same thing can happen in even rheumatoid arthritis with long-term immunosuppression. So these are the things we, as a doctor, we have to consider. In emergency room, we have only put an ICD and stabilize the patient. But if the patient is having repeated pneumothorax like this, without any major reasons, if the patient is on immunomodulators, there is a chance of PCP infection. Okay. Like tuberculosis also can happen, that we have to rule out.
Some bacterial pneumonia and lung abscess can also cause pneumothorax. Then secondary pneumothorax, most probably any underlying lung condition should cause, like COPD or asthma, cystic fibrosis, or interstitial lung diseases, sarcoidosis, pulmonary fibrosis, or connective tissue disorder like Marfan's, Ehlers-Danlos, and even primary lung cancer can cause pneumothorax. Diagnosis basis, we can do ultrasound, X-ray.
Marfan's is another important reason for spontaneous pneumothorax. You can get many patients with Marfan syndrome. They will have, what is the reason for pneumothorax there?
Elasticity.
What is the reason? Reason for pneumothorax in Marfan syndrome? It is bullace. She told elasticity that produces bullace. You can see, if you take a CT scan in such patients, you can see multiple bullace. Okay, so that is a possibility.
Diagnosis X-ray we can do. X-ray we can see lung borders with no air markings in the pneumothorax area. An ultrasound showing decreased air entry and barcode sign. Then CT definitely.
There is a normal sign in ultrasound.
Seashore sign.
Okay.
Then CT can also be done. Treatment basis depending on the size, we can. I mean, if it's a first time spontaneous.
If you recurrent pleural fistula, what else you can do? Bronchopleural fistula, what else you can do? Recurrent. This patient is coming recurrent. This one. So after sometimes, what else you can do if the patient is not relieved with routine treatment?
Definitive fistula closure can be done.
If it is one or two fistulas, you can close. If it is multiple fistulas like this, what do you do?
Chemical pleurodesis.
Pleurodesis is a treatment of choice then. Okay.
Then it's a small, we can observe for more than 3 hours with oxygen, and small size catheter can be placed or small size aspiration can be done. If it's a small secondary pneumothorax also, catheter or chest tube. In a large pneumothorax, either primary or secondary or bilateral, we will put a chest tubes and admit the patient, and fluid or hemo with the water seal should be there. And tension pneumothorax, immediate needle decompression followed by moderate to large size tube, ICD tube placement for further management and definitive course of.
What happened to this patient afterwards?
Afterwards, CVTS admitted the patient and
What they did?
They did pleurodesis.
Pleurodesis.